upper gastrointestinal bleeding UGI.
Hmm?
It's a really serious medical emergency.
Absolutely. It's frightening, it's critical, and often needs that urgent scope, the endoscopy, to figure out what's going on and stop it.
Right. And while all that diagnosis and intervention is happening, what about medications?
Yeah.
Can giving certain drugs, like right at the start,
Yeah.
before the scope even happens, or maybe alongside other treatments,
Yeah.
does that actually make a difference, a real difference?
That's the million-dollar question, isn't it? We're not just asking if it changes, say, what the doctor sees during the procedure.
No.
We really want to know if these drugs impact the big things. Does the patient survive? Do they end up bleeding again? Do they need major surgery?
Exactly. Those are the outcomes that matter. And today, we're doing a deep dive into the evidence. We've got some really good systematic reviews here, including some key Cochrane analyses.
Yeah, good stuff.
We're looking specifically at 3 different medication strategies for acute UGI. First, antibiotics, then proton pump inhibitors, or PPIs, and finally, somatostatin analogues.
And our mission, really, is to sort of cut through maybe some common practices or assumptions and see what the best available evidence from these big reviews actually tells us.
And therefore, what it tells you, the listener, do these drugs in these specific situations genuinely move the needle on those really critical patient outcomes?
Let's find out.
Okay, let's start unpacking this. Let's begin with a very specific group. Patients who have cirrhosis and then develop upper GI bleeding.
Now, antibiotics, why are they even considered? Seems a bit strange, right? Fighting infection when the problem is bleeding.
Well, it's actually fascinating. Cirrhosis itself really weakens the patient's immune system. Their defenses are down.
Okay.
And then you add an upper GI bleed on top of that. It's like a perfect storm. The sources we looked at explain that the bleeding episode itself can increase something called bacterial translocation.
Bacterial translocation, meaning...
Basically, yeah, bacteria that normally live in the gut start to leak out, get into the bloodstream where they shouldn't be.
Ah, okay. So the bleed isn't just blood loss. It actually triggers this risk of infection in people who are already vulnerable because of the cirrhosis.
Precisely. And we're talking serious infections here. Things like SBP, spontaneous bacterial peritonitis, an infection of the abdominal fluid.
Right.
Also urinary tract infections, pneumonia, even bacteremia, bacteria actively circulating in the blood. These are common, and they make outcomes much, much worse for these patients.
Got it. So the idea behind antibiotics is purely preventative. Stop these infections before they start.
Exactly. It's prophylaxis.
Mm-hmm.
And the evidence, well, there's a key review from 2010, Chavez Tapia, that looked right at this question.
And what did it find? Did giving antibiotics actually prevent those infections?
It really did, quite dramatically, in fact. The review pooled data from multiple trials and found that using antibiotic prophylaxis, giving those preventive antibiotics, it slashed the risk of bacterial infections by over 60%.
Wow, 60%. That's a huge reduction.
It's a massive impact, yeah, on a really common and dangerous complication for this group. Okay, so preventing the infection is clear. But did that translate? Did it actually make the patients better overall? Did they, survive more often?
Well, it certainly looks that way. The review suggested benefits across several really important outcomes. Maybe the certainty isn't quite as rock solid as the infection prevention itself, but the trend was definitely towards improvement.
Such as?
It seemed to reduce mortality from any cause. It seemed to cut deaths specifically caused by bacterial infections. And it also appeared to lower the risk of the patient bleeding again.
Any other benefits?
Yeah, patients also seemed to spend less time in the hospital, on average almost 2 days less, which is quite significant.
And this benefit was seen against all those infections you mentioned. SBP, UTI, pneumonia.
Yes. The evidence showed significant reductions across the board: bacteremia, pneumonia, SBP, UTIs. Antibiotics seemed pretty effective at preventing that whole range of dangerous infections in this specific setting.
Okay, sounds impressive.
Yeah,
What about downsides? Any serious side effects popping up in these trials?
that's a crucial point. The analysis found no evidence of serious adverse events linked directly to the antibiotic treatment itself in these studies.
And did it matter which antibiotic they use? Is there one specific drug we should be thinking about?
Actually, no. And this is really key from the review. Those benefits preventing infection, potentially boosting survival, reducing rebleeding, they were seen pretty much independently of the specific antibiotic agent used in the trials.
Really? So it didn't matter if it was pills or IV?
Not really. The trials included all sorts. Oral quinolones like norfloxacin, IV cephalosporins like ceftriaxone, but also other types like beta-lactams, aminoglycosides, even trimethoprim sulfamethoxazole. The benefits seemed consistent across different classes.
So the big takeaway isn't use drug X. It's more about the strategy of using an antibiotic in this specific patient group.
Precisely. The implication for practice is implement this preventive strategy. But which antibiotic you choose? That should probably be guided by local factors, what bugs are common in your hospital, what are the resistance patterns like? And of course, cost is always a consideration too.
Right. So if we're connecting this back to you, the listener, what's the bottom line here?
I think the bottom line is if you or perhaps someone you know has cirrhosis and then has an upper GI bleed, the evidence very strongly supports using antibiotic prophylaxis. It should be a core part of their immediate care plan.
Because it seems really effective at stopping those serious infections.
Very effective. And it likely improves other critical things like survival and how long they need to stay in hospital. It feels like a really powerful, targeted intervention for a specific high-risk group.
Okay, very clear. So antibiotics show a definite benefit by tackling complications in that cirrhotic population. Let's shift gears now. Let's talk about a different class of drugs, ones used much more broadly for UGG, perhaps. Proton pump inhibitors, PPIs.
Yes, the acid blockers. These drugs work by drastically cutting down stomach acid production.
In this next review we looked at, Sridharan, from 2012, it focused specifically on starting these PPIs before the patient even gets to endoscopy, which, anecdotally at least, seems like a really common thing to do.
It is very common. The thinking behind it is, well, if you reduce the acid, maybe you help stabilize any blood clot that's formed over the bleeding spot.
Making it less likely to break down.
Yeah, potentially stopping the bleeding or at least making it less severe or easier to treat when they do the scope. That's the rationale.
Okay, makes sense theoretically, but what did the evidence actually show? This review pulled together 6 randomized trials, over 2,200 people. Did starting PPIs early actually provide those clinical benefits?
Well, here's where it gets interesting. When they pooled all that data and looked at the really crucial patient outcomes, mortality, rebleeding within 30 days, needing surgery because of the bleeding.
The big ones.
The big ones, yeah. They found no statistically significant difference between the group that got the PPI before the scope and the control group.
No difference, even though it's done so often.
No statistically significant difference. The control group, by the way, might have received a placebo or maybe a weaker type of acid blocker like an H2RA or sometimes just no treatment before the scope. But comparing PPIs to those controls, no clear win for the PPIs on those major outcomes.
That's quite surprising. So starting the PPI early didn't demonstrably change the odds of dying, bleeding again later, or needing an operation.
Correct. When you look at the actual numbers, the rates for mortality, rebleeding, and surgery were really quite similar in both groups. The statistical analysis, the odds ratios, they just weren't significantly different from 1-1. Any small differences they saw could easily have just been down to chance.
Okay. So no clear benefit on the major clinical endpoints. But the review did find some differences related to the endoscopy itself, right? What the doctors actually saw during the procedure.
It did, yeah. That's where there was a statistically significant difference. Starting the PPI before the scope did significantly reduce the proportion of patients who had what they call stigmata of recent hemorrhage, SRH, at the time of the scope.
Stigmata, like the visual signs of bleeding.
Exactly. Things like active oozing or seeing a blood vessel sticking out of an ulcer base or maybe a clot that's still attached. PPIs reduced how often the endoscopist saw those things.
Okay. And anything else found during the scope?
Yes, it also significantly reduced the need for the endoscopist to actually perform endoscopic therapy right then and there. Things like injecting adrenaline or applying clips to stop the bleeding. Fewer patients needed that immediate intervention during the index endoscopy if they'd had a PPI beforehand.
Okay. So it seemed to make the bleeding site look a bit less active and maybe meant fewer immediate interventions during the scope itself. And this sounds like a big but.
It is a big but. The review authors themselves pointed out a couple of crucial caveats here. First, that finding about reduced stigmata, it wasn't entirely robust. It kind of weakened when they did sensitivity analyses, looking at the data in different ways.
Okay.
And maybe more importantly, they questioned the actual clinical significance of these findings. Okay, so you change what the scope looks like, or maybe you do slightly fewer interventions at that moment. But if that doesn't ultimately translate into better overall outcomes for the patient, like improved survival, less rebleeding later on, avoiding surgery, then how important is that change, really? The clinical value becomes uncertain.
Right. If it doesn't change the big picture for the patient, does changing the picture during the scope matter that much?
That's the question they raise.
So what was the author's bottom line, their summary conclusion from all this evidence?
They basically concluded that, yes, giving PPI therapy before endoscopy is very widespread. But based on this analysis, it didn't seem to significantly improve those really important clinical outcomes: rebleeding, surgery, or mortality.
Did they see any role for it at all?
They did suggest it might still have a role if there's likely to be a significant delay in getting the patient to endoscopy. Maybe if you're in a setting where scopes aren't available 24/7, perhaps it could help stabilize things temporarily in that situation.
A temporizing measure, potentially.
Potentially. But they also added that if the endoscopy is done promptly, and maybe it finds no bleeding source, or finds that the bleeding is clearly coming from something else, like varices.
Which we'll get to next.
Exactly. Then the evidence doesn't really support just continuing the PPI simply because it was started beforehand.
And did they look into whether the type of PPI mattered, or whether giving it IV versus by mouth made a difference?
They did look at that with subgroup analyses. The trials used various PPIs, omeprazole, lansoprazole, pantoprazole, and different routes. But based on their analysis, none of those factors seemed to significantly change the main findings regarding mortality, rebleeding, or surgery.
Okay, so the takeaway on pre-endoscopy PPIs is, well, it's a bit underwhelming, isn't it? It might change the view at the scope, might reduce immediate interventions then, but the link to better major outcomes like survival or avoiding rebleeding or surgery seems weak based on this review.
It certainly challenges a very common practice, yeah. It makes you question if we're targeting the right thing or maybe using the right tool at the right time if those major outcomes aren't clearly improved.
Definitely food for thought there. Okay, let's turn now to our third area. This brings us back potentially to patients with cirrhosis, although varices can occur for other reasons too. We're talking about bleeding specifically from esophageal varices.
Right. These are those swollen, fragile blood vessels in the esophagus, often linked to high pressure in the portal vein system, commonly seen in advanced liver disease.
And when they bleed, it can be catastrophic. So this review, Gotcha from 2012, looked at a different class of drugs, somatostatin and its synthetic analogues, things like octreotide or vabriotide.
Exactly. These drugs work quite differently from PPIs. They cause vasoconstriction, they tighten up blood vessels, particularly in the splanchnic circulation, which is the system feeding the gut and liver.
So the idea is to reduce blood flow to the varices.
Precisely. Lower the pressure within those swollen varices, which should hopefully help stop the bleeding. This review looked at 21 trials that compared giving these drugs, usually intravenously, sometimes subcutaneously, against either a placebo or just no specific vasoactive drug treatment.
And it's important to note, patients often got other treatments too, right? Like banding during endoscopy.
Oh, absolutely. In many, probably most of these trials, patients were also receiving standard care, which often included things like endoscopic sclerotherapy or band ligation procedures where the varices are directly treated during the scope. So these drugs were typically tested as an addition to that standard approach.
Okay, so adding these drugs,
No.
did it help? Let's start with the biggest outcome, mortality. Did using somatostatin or its analogues save lives in patients with acute variceal bleeding?
Well, when they crunched the numbers from all 21 trials, looking at over 2,500 patients, the answer was pretty clear. No. The drugs did not show a statistically significant benefit in reducing mortality.
No survival benefit.
Not a clear one, no. The risk of dying was very similar whether patients got the drug or the control treatment, and that was especially true when they focused on the trials considered to be of higher quality, the ones with a lower risk of bias.
Okay, so survival wasn't improved. What about the bleeding itself? Did the drugs help control the bleeding or reduce the need for, say, blood transfusions?
They did seem to have some effect there, yes, but maybe modest effects. Patients who received the drug generally needed fewer units of blood transfused.
How much less?
In the better quality, low-bias trials, it was about half a unit less per patient on average,
Right.
maybe slightly more in the trials considered higher risk of bias, around 1.5 units less there.
Half a unit. Okay, what about stopping the bleeding initially? Did it help with that?
Yes, the drugs did seem to increase the number of patients whose bleeding was successfully stopped right at the beginning. They improved what's called initial hemostasis, getting control of the bleed early on.
Okay, so helps stop it initially, saves a bit of blood. What about preventing rebleeding later on?
Now this is where things get really interesting and where the quality of the studies becomes absolutely critical. It's a major point the review authors emphasized.
How so?
In the trials that were judged to have a low risk of bias, generally the better designed, better conducted studies with things like proper blinding and allocation concealment,
Right.
in those trials, there was no statistically significant reduction in the rate of rebleeding.
No difference in rebleeding in the good trials.
Correct. However, if you looked at the other trials, the ones considered to have a higher risk of bias, in those studies, the drugs appeared to substantially reduce rebleeding, like a really big effect was suggested.
Wow. So the less reliable trials made the drug look much, much better for preventing rebleeding than the more reliable trials did.
Exactly that. It's a stark illustration of how bias can creep in and really inflate the apparent benefits of a treatment, particularly things like lack of blinding, where the doctors or patients know who's getting the active drug versus placebo, seem to be a major issue.
How would that affect results like rebleeding or transfusions?
Well, the authors specifically point out that things like the number of blood transfusions needed are what we call a surrogate outcome. It's not survival itself. And it can be quite subjective, especially in an unblinded trial.
You mean a doctor, knowing the patient got the active drug, might be slightly less likely to order a transfusion, even subconsciously?
Potentially, yes. Or their threshold for defining rebleeding might shift slightly. That's why blinding is so crucial for these kinds of outcomes. Unblinded trials consistently reported saving more blood and seeing bigger reductions in rebleeding than the blinded trials did. The authors really hammered home that survival is the most objective and important outcome, and these drugs didn't clearly improve that.
Okay, so given all that, no clear survival benefit, modest effect on transfusions, questions about the rebleeding data due to bias, what was the overall conclusion from the Gusher review authors?
Their conclusion was pretty cautious, even skeptical. They stated that the effect on blood transfusions, saving maybe half a unit per patient in the reliable trials, was of doubtful clinical significance. Basically, is that small saving really meaningful for the patient?
They questioned its value.
They did. And they went on to say that based on these findings, they didn't really see a strong need for more placebo-controlled trials of this type, implying that running more small trials looking for these modest effects probably isn't the best use of resources.
Did they think a bigger trial could settle the mortality question?
They acknowledge that you'd need a truly enormous trial to definitively rule out some small but worthwhile effect on mortality. But they also suggested that showing such an effect was highly unlikely, and launching such a huge, expensive trial would be very difficult to justify given the current evidence.
Right. So for acute variceal bleeding, the bottom line seems to be these drugs might help stop the initial bleed, they might save a small amount of blood, but the impact on survival is just not there in the current evidence. And the clinical relevance of the benefits they do provide is questioned by the researchers themselves.
That sums it up pretty well, yeah, especially when you factor in the concerns about trial quality influencing some of the results.
Okay. Let's try and pull these threads together now. We've done this deep dive into 3 different drug strategies used around upper GI bleeding, antibiotics for cirrhotics, early PPIs for general UGIB, and somatostatin analogues for variceal bleeds. What are the big picture takeaways? How does the evidence really stack up across these different approaches?
I think the clearest takeaway is just how different the evidence is for each. It really highlights that UGIB isn't one single thing and the interventions need to be targeted.
Right. So summarize the differences again.
Okay, so first, antibiotics in patients with cirrhosis who are bleeding. There, we saw strong, consistent evidence of a major benefit. It's all about preventing those dangerous secondary infections.
And that prevention likely leads to better survival, less rebleeding.
Exactly. A clear win by targeting a specific known complication in a vulnerable group.
Okay. Then PPI started before endoscopy.
Much less clear-cut. Despite being common practice, the review we looked at found no significant impact on the major clinical outcomes: death, rebleeding later, needing surgery. It did change things seen during the scope, maybe reduced immediate interventions then.
But the clinical value of that was questioned if it doesn't change the patient's overall course.
Right. The authors suggested maybe a role if endoscopy is delayed, but otherwise the evidence for improving major outcomes wasn't convincing.
Okay. And finally, somatostatin analogues for variceal bleeding.
Again, a bit underwhelming on the big picture. Modest benefits seen, like helping stop the initial bleed, saving a small amount of blood. But these were deemed potentially of doubtful clinical significance.
And crucially, no clear survival advantage.
No clear survival advantage, and real concerns about how trial quality, particularly lack of blinding, might have inflated some of the other apparent benefits like reducing rebleeding in the less rigorous studies.
Yeah, that somatostatin review was a powerful reminder about critically appraising study quality, wasn't it? Bias can really skew results.
Absolutely, especially for outcomes that have some subjectivity, like deciding when someone has rebled or when exactly to transfuse. Blinding and proper randomization are just essential for reliable answers.
So it really hammers home the point that treatment has to be tailored, doesn't it?
Yeah.
You need to know why the person is bleeding. Is it varices? Is it an ulcer? And what's their underlying condition? Do they have cirrhosis? It's not a one-size-fits-all medication approach.
Definitely not. It's about understanding the specific pathophysiology. Are you trying to stop acid, prevent infection, lower portal pressure? And then looking at the evidence for interventions that target that specific problem and demonstrably improve outcomes that matter.
Okay, so we've seen this real variation in the strength of evidence and the clinical significance of the effects. Strong evidence for preventing infection in cirrhosis with antibiotics. Less certainty about the value of early PPIs. Modest, possibly clinically doubtful benefits for somatostatin analogues in varices. Considering all this,
Yeah.
what does it tell us about just how complex managing acute bleeding really is?
It's incredibly complex.
And maybe, thinking ahead, where should research efforts be focused to make the biggest difference for patients facing this kind of emergency? What's the next frontier?
That's a great question. I think it tells us that simply intervening because we can or because an intervention changes an intermediate number isn't good enough. We need to focus on things that demonstrably improve patient-important outcomes like survival, major morbidity, maybe even quality of life down the track.
So more focus on the big picture.
Yeah, and maybe the contrast between the clear benefit of antibiotics targeting a systemic vulnerability, infection risk, and cirrhosis, and the less certain benefits of the other drugs focusing more locally on the bleed itself. Maybe that tells us something. Perhaps future research needs to think more holistically. Understanding and mitigating those underlying patient vulnerabilities might be just as important or even more important than just focusing solely on the bleeding site itself. Maybe that's where the next big gains are to be found.